Witam. That's the first thing I want to say in Polish. So thank you to the organization for bringing us to such a beautiful city. It's my third time here, and I love it more every time I come back. So today, I'm going to talk to you about new treatment strategies for Waldenstrom's macroglobulinemia. I am the clinical director of the Waldenstrom's program at the Dana-Farber Cancer Institute in Boston. We are a team of about 3 different clinicians and a number of other researchers. We do have a large clinic there. We get to see about 1,500 visits of Waldenstrom patients per year in our clinic, so we're lucky that people from all over the country come to see us. And what I'm going to be talking today is about our experience, and obviously the experience of others as well in how to treat this disease. My email address is right there. It's going to be in your booklets as well. If you have any questions about patients, if you like the slides, please feel free to reach out to me, and I'll be happy to help you in any way possible. These are my conflicts of interest when I live there for a few seconds. In my clinic, it's very important to know if somebody has Waldenstrom's. And as of today, the way we make the diagnosis of Waldenstrom's in my clinic is using these 3 variables. We do have almost always an increase on a monoclonal serum IgM. We do have an excess of lymphoplasmacytic cells in the bone marrow, making the diagnosis of lymphoplasmacytic lymphoma. And the last one is the presence of this somatic mutation in the gene MYD88. Now, I want to be very clear. If you use any of these alone, it's not diagnostic. You have to put the 3 together to make a very likely statistical diagnosis of Waldenstrom's macroglobulinemia. And finally, I want to say that the diagnosis of Waldenstrom's is actually clinical pathological. It's not purely pathological or purely clinical. It has to be a combination of both. Now, the difference between Waldenstrom's and myeloma and amyloidosis, which is what we just heard, is that a large proportion of our patients are actually asymptomatic at the time that they present. That obviously varies from practice to practice. In my practice, about 30% of our patients are asymptomatic at the moment of diagnosis. In other practices, it might be a little different. But there is a condition in which patients have the diagnosis of Waldenstrom's, but they are otherwise asymptomatic. In patients who are asymptomatic, and that is the second important message of my lecture, is those patients should be monitored without intervention. And that sometimes is a hard sell because we are trained to intervene and try to help, and sometimes just observing doesn't seem like an optimal thing to do, but there are many reasons to do that. Number 1, we do not cure Waldenstrom's as of today. We don't have a cure. We're a bunch of people, some of us in the room, working on trying to cure Waldenstrom's. We don't have a cure as of today. Number 2, patients with Waldenstrom's have a long survival. You know, the long survival can be approaching an average of 15 to 20 years. So, you know, it's very unlikely that a 6-month regimen of chemotherapy is going to modify a 20-year survival. So we do not prolong survival in most patients with Waldenstrom's. On the other hand, our therapies, which are great, we'll see that in a second, have toxicity and also induce resistance. So for all those reasons, if you have an asymptomatic patient, the best thing you could do is to observe. On the right, we can see a study that we did on asymptomatic patients with Waldenstrom's, 439 patients at Dana-Farber and other centers. We put our experience together, and we saw that about 10 years out from diagnosis, 80% of patients needed therapy, 20% did not. That means 1 out of 5 patients with asymptomatic Waldenstrom's might not need treatment for longer than a decade. So I think it's important that we let our patients, you know, follow and let us know if they actually might fall within that category of patients who might not need treatment for a long time. We actually developed a prognostic score that which you can access online. You can go to awmrisk.com, and you can enter the patient's percentage of bone marrow involvement, serum IgM levels in milligrams per deciliter, serum beta-2 microglobulin, and serum albumin. All those values need to be taken at the same time. It's not fair to use the bone marrow from 2015 with the IgM from 2020. It has to be almost at the same time. And you basically click on calculate their score, and you have their score on the right side. In this patient example, this patient is an intermediate category patient, which means that if we take 100 patients like this, half of the patients will need treatment within 5 years. The other half will go beyond 5 years without needing treatment. So there are 3 categories. The low-risk categories, which is the median is 9 years. The intermediate, the median is 5. And the high-risk category, the intermediate time to treatment is 2 years. Now, this doesn't tell me who needs treatments. The way I use this scoring system is it helps me how often I need to follow my patients. If a patient is a low risk, I try to follow them at least once a year. If it's intermediate risk, every 6 months. If it's low risk, every 3 to 4 months. And obviously, that's a decision that a physician can make. Now, most of our patients, however, will be symptomatic at some point of their disease. And this is just the wide variety of clinical symptoms that a patient with Waldenstrom's can have. When I joined Dana-Farber 10 years ago, they told me you have 3 months to decide if you're going to be the next Waldenstrom specialist. And it took me 3 weeks to actually make that decision when I saw the wide variety of clinical significance. It's interesting to know that patients with Waldenstrom could be very different one from the other. You can have a patient with anemia, which is a classic patient that we see very often. But we can see the patient with neuropathy. And the patient with neuropathy almost never will be anemic. Or you can have the patient with hyperviscosity. And those patients very rarely will be neuropathic. So you can have patients with multiple different clinical features, but they all meet the 3 criteria that we talked about earlier, so we can make a diagnosis of Waldenstrom's. We have hyperviscosity, neuropathy, cold agglutinin disease, cryoglobulins. Some cases can have AL amyloidosis. We can have kidney involvement, 2 to 3%, not as much as myeloma, even though most of our patients have a very high levels of free light chains. So that's I think the free light chains in myeloma behave differently than the free light chains in Waldenstrom's. We do have a rare condition called Bing-Neal syndrome, which is a condition in which the Waldenstrom cells access the brain and the spine and causes some neurological deficits. That is seen in about 1 to 2% of the patients. So again, talking about clinical variety, we need to be very careful about all these features. And when I see a patient who's asymptomatic, I ask them all these questions to make sure that all these different organs and systems are being evaluated properly. Now, when we get to treat our patients, we do have a number of standard regimens. Before I get into the new treatments, I want to talk to you very briefly about the standard regimens. And we have been using chemoimmunotherapy for, close to 2 decades, and it's an excellent treatment. It works very, very well. Highly efficacy. As you can see there, response rates between 80 and 90%, major response rates, which is at least a decrease on the IgM by 50%, between 70 and 80%, and progression-free survivals that can be measured in years. The second group of therapies are in the bottom of the table, which are the proteasome inhibitors, which we borrowed from the myeloma world. We combine them with rituximab as well. There's prospective data that I'm showing right there, highly competitive with chemoimmunotherapy. So how do we select between these regimens? And that's where the science becomes an art. You have to talk to the patients. You have to understand who they are, what they need, what's their age, what's their genomic profile, comorbidities, and all these other features to understand what they might be the best outcome for these patients. Now, chemotherapy, despite its highest efficacy, has some toxicity. We need to be careful about secondary myeloid neoplasms, and that is something that is more important in somebody who's going to be alive for the next 20 years. On the other hand, proteasome inhibitors, we can have some cardiopulmonary diseases with carfilzomib. We can have some neuropathy with bortezomib and ixazomib. And we also need to be aware of the IgM flare that can be seen with rituximab. So all these different aspects that are very Waldenstrom-centric, we need to have in mind when we recommend therapies for our patients. For the longest time, we used maintenance. And we used to do that basically based on the data from follicular lymphoma and other indolent lymphomas using rituximab. But this study that was presented at ASH in 2019 and updated recently at the Waldenstrom workshop last year showed us that really if you got a nice response, partial response or better with bendamustine and rituximab, if you randomized to observation versus maintenance rituximab, there was no progression-free survival benefit or overall survival benefit. And for that reason, now we are using much less and less maintenance in patients with Waldenstrom's. Just to clarify that this study has not yet been published, so we don't have a formal peer-reviewed paper just yet that I'm aware of. And then the BTK inhibitors came around. We now have been using BTK inhibitors for about 10 years in the United States. Ibrutinib was the initial BTK inhibitor, and now we have second and third generation BTK inhibitors and the new non-covalent BTK inhibitors, which I'll talk about in a second. This is a table in which I put here a few examples of clinical trials, prospective, using BTK inhibitors in Waldenstrom's. We do have the initial study on the top. This is the study that was led by my mentor, Stephen Trion, at the Dana-Farber Cancer Institute, that got ibrutinib approved by the FDA for Waldenström, the first medication formally approved by the FDA for Waldenström's from our group. 63 patients, 91% response rate, 73% major response rates, and a median progression-free survival, five-year progression-free survival of 54%. Now, we do have also some data with ibrutinib in the frontline setting. We have the INNOVATE study that combined ibrutinib with rituximab, and then data with acalabrutinib and zanubrutinib. And as you can see, the response rates and the major response rate and survivals are impressive. And not only that, they're very competitive with chemotherapy. The problem that we have in Waldenstrom's, which, that's why I envy sometimes myeloma, is that we don't have any head-to-head comparisons between chemoimmunotherapy and BTK inhibitors. Such a study in a randomized fashion has not been done. So it's very hard for me to say, I think BTK inhibitors are better, or I think chemoimmunotherapy is better. I think you need to talk to the patient and understand what they need, and therefore make a decision at the time. Now, BTK inhibitors have their own problems. They have their own side effects. And even though they might not have a myeloid problem, they might not cause neuropathy, or they might not cause IgM flares, we do have bleeding, we do have arrhythmias that could be atrial, but a little bit ventricular as well in some cases. We can have bleeding issues and other problems. So we need to balance that out as well. Other downside of BTK inhibitors is that you need to take these treatments indefinitely. These are not treatments that we can stop. At least there's no data that we can do that just yet. So these patients take these medications for years. Just to give you an example, about 20% of the patients who started the first clinical trial in 2012 are still on ibrutinib 11 years later and taking ibrutinib every day. So these treatments can be very durable as well. I think an important development was the first randomized study comparing two BTK inhibitors. Actually, this happened first in Waldenstrom's than in CLL, and we're proud of that. So we actually saw a comparison between zanubrutinib and ibrutinib. It's about 100 patients per arm. And this study wanted to show that zanubrutinib could induce a higher rate of VGPR than ibrutinib. At the time of the first publication, there was no statistical difference, 28% VGPR for zanubrutinib versus 19% for ibrutinib. So that was not statistically significant. And as you can see, the progression-free survival, and that's actually a follow-up of 18 months, there were no differences between the two groups. However, we did see a lower rate of atrial fibrillation and a lower rate of hypertension with zanubrutinib, and that actually led to the approval of zanubrutinib by the FDA in 2021. Now, this study was just actually came out in publication a couple of weeks ago, and this is the long-term follow-up on this treatment, and we actually saw that zanubrutinib actually might be a little bit of a difference in the progression-free survival curves compared to ibrutinib. The problem with this is the study was not powered to show that difference, so I want to be very clear about that. We do see that the responses do deepen in both groups, but still seems to be numerically at least higher with zanubrutinib than with ibrutinib. In the toxicity profile on the bottom, you can see sustained up to the 3-4 years in which there's lower risk of atrial fibrillation, lower risk of hypertension, lower risk of bleeding with zanubrutinib than with ibrutinib. We do have some data in CXCR4 patients. CXCR4 mutations are seen about 30 to 40% of patients with Waldenstrom's. In our initial research, showed that it could make the responses to ibrutinib a little less durable. Zanubrutinib seems to be at least numerically superior than ibrutinib in patients with CXCR4 mutations. We can see here a VGPR of 21% versus 10%, and a little bit of a separation on the progression-free survival curves, even though there's no statistical difference at this time. Obviously, there have been a lot of, with new treatments, we can have now options to treat patients. And for the longest time, when a patient was taking ibrutinib and he was having some toxicity, we actually just managed the toxicity, and we tried to keep the patients on a very good compliance rate. But nowadays, with the newer BTK inhibitors, and we have some data now in dose reductions on BTK inhibitors that actually sustain the response despite of the dose reduction, then we have been able to look at other options. So when somebody becomes intolerant to one of the BTK inhibitors, one of the first approaches will be to manage the symptoms, but the other approach will be to actually decrease the dose. And we have some data I'm going to show you in a second. If you exhausted this option, you can move into the second option, which is actually switching. You can switch from ibrutinib to acalabrutinib, or from ibrutinib to zanubrutinib, from acalabrutinib to zanubrutinib. And I actually switched some patients from zanubrutinib to ibrutinib because they were having too many side effects to one, then I'll go back to the next. And the efficacy, when we talk about side effects, is actually sustained. Or you could choose to abandon BTK inhibitor therapy based on side effects. If somebody's progressing on a BTK inhibitor, I don't think the other covalent BTK inhibitor is going to help, but this is only in the setting of intolerance. This is data from my colleague, Shayna Saroshek from the Dana-Farber. We did a study of our, over 400 patients on ibrutinib that we had in our clinic, and we realized that about a quarter of these patients had to have a dose reduction from 420 to 280 milligrams once daily. And we can see there that women and individuals over 65 actually had a higher rate of dose reductions. But despite that fact, 80% of the patients actually sustained or even deepened the response despite the fact that the dose was reduced. We have a similar experience with Zanabrutin that we have not published yet, but we are actually in the process of collecting these data. This is not venetoclax, is used now in Waldenström. So it's not FDA approved, but it's actually endorsed by the National Committee, which is the NCCN. And this is data that we presented, we published last year on JCO. We actually did 2 years of venetoclax, and you can see how the progression-free survival is going very well until the 2-year mark, and then basically it starts falling. So it looks to me that we can optimize venetoclax therapy in patients with Waldenström, maybe more durable, maybe a response adapted duration of therapy. But based on these data, we are now looking forward on combining BCL2 and BTK inhibition, as we will see in the next slides. So what are the new treatment strategies? I think one of the important studies is the comparison between BTK inhibitors and chemotherapy. And the British are doing this study, the Rainbow study, in which they're going to compare ibrutinib rituximab versus CRD, which is a chemoimmunotherapy regimen. They're attempting to enroll 148 patients, 1-to-1, treatment naive. So I think that's a very interesting study, and we will see those results hopefully coming up in the near future. Another study coming from Germany, they're actually combining venetoclax and rituximab in the frontline setting, and there's a bit randomized phase 2 study as well. So another study looking at targeted agents versus chemoimmunotherapy, a very interesting study as well. We did our own study at Dana-Farber combining ibrutinib and venetoclax. I mean, that combination showed benefit in chronic lymphocytic leukemia and also mantle cell lymphoma. So we did a study and we presented this at ASH last year. We saw a very high rate of responses. However, there were 4 events of ventricular arrhythmia, and 2 of them are actually fatal. So for that reason, we stopped the study therapy. We stopped on all patients by March of last year, but we continue to follow those patients over time, and we will be presenting some data of therapy at ASH this year. This is the side effects, really nothing too different besides the ventricular arrhythmia. And the concerns of tumor lysis syndrome with venetoclax in CLL was very high, but in Waldenström we saw only 2 cases. They were laboratory, managed in the office, outpatient. Patient did not need to be admitted, and there was no clinical evidence of tumor lysis syndrome. The other agent that is actually very interesting is the non-covalent BTK inhibitor, pirtobrutinib. It's a different agent. It's a BTK inhibitor as well, but it binds to BTK in a different way that does not involve 481, which is where the mutations happen when patients get exposed to Zanu, Acala, or ibrutinib. And we did see, the column in the middle, the 63 patients with prior exposure to BTK inhibitors, a nice response rate of 67%, and a VGPR of better than 24%. So highly encouraging data. These are patients that are progressing or were exposed to other BTK inhibitors previously. I think the progression-free survival, the median was about 19 months, which is not great, but the follow-up is also short. So my sense is with more follow-up, we might see actually an improvement on that progression-free survival. But as of today, what was presented last year was a median PFS of 19 months. Based on this, we actually are accruing patients for a study combining pirtobrutinib and venetoclax. This is for previously treated patients. We have about 8-9 patients enrolled in that study already, and we're not going to be able to present any data this year, but maybe for next year we'll be hearing the results of this study, and we're actively enrolling at the moment. The Canadians came up with a nice idea of actually combining chemoimmunotherapy with a BTK inhibitor. So they did 6 cycles of Benda-R, 1 year of acalabrutinib. So you include a BTK inhibitor, you do a finite duration therapy, it's a triplet. So actually it's a very interesting concept. At ASH, 8 out of the 10 patients actually got into a VGPR. 80% VGPR is actually a very interesting concept. I want to tell you that, have you heard me say complete response? I haven't used the word complete response just yet in Waldenström. And the truth is, we almost don't get to complete responses. So I'm jealous not only from myeloma, but also from CLL. We're talking about MRD negativity. Those are concepts that we are not managing just yet in Waldenströms. Complete responses are very rare. Even with bendamustine and rituximab, the complete response rate is less than 5% based on the Rommel data presented recently. So that's what we're trying to get. We're trying to get the complete response and hopefully to get to a cure from this disease. Immunotherapy is coming up. We do have loncastuximab tesirine. My colleague, Dr. Saroshek, is running a study. We have several patients enrolled on this study already, showing some benefit as well. And the new player here is CLR131. It's a radioisotope. Initial data presented as 16% CR. So that's obviously very exciting. It's 4 infusions of a radioisotope. So this is a study that is running. They're about to complete accrual. So it will be very interesting on seeing what this study has to say in the near future. To conclude, the diagnosis of Waldenström's can be made by looking at IgM elevation, LPL infiltration, and the MYD88 mutation. The second message is please reserve therapy only for symptomatic patients. I think that you will be doing the right thing by your patients. We have a number of treatment options that are safe and effective in patients with Waldenström's. And always, I think the answer is on clinical trials. And obviously, we're using now combinations of covalent BTK inhibitors, non-covalent BTK inhibitors, and immunotherapy. And with that, I want to thank you for your attention, and I remain available for your questions.
Thank you very much for excellent presentation. And the presentation is open for discussion, for questions.
Dr. Kasridis.
As always, excellent presentation. My question is, do you know anything, do you have any data?
Oh, I can repeat your question.
Do you know anything, or you know, of course, but do you have any data about the bispecific antibodies targeting CD20 in Waldenström's, who are, are coming very fast in other types of CD20 positive lymphomas?
So we are very excited about that. We don't have any preclinical data. Actually, before ibrutinib and before venetoclax, we have very robust preclinical data, right? Laboratory data showing efficacy before we got into these studies. We don't have a lot of preclinical data with any of these immunotherapies. But my colleague at the Beth Israel Deaconess Medical Center in Boston, Dr. Gottfried von Keudel, he's actually thinking about a study with one of the anti-CD20 antibodies. So we proposed already a letter of intent, which has been formally accepted. It's going to be a multi-center study. So we're going to be, studying that hopefully for the future, but we have not started accrual on that study just yet. But yeah, we're really looking forward to that. And CAR T cells is also up and coming. There's a company called Mustang Bio that is also targeting CD20. So that's another program that we are actually trying to put together. We were moving forward with Kite, with the CD19 Brexu cell, but then Kite decided to kill that program for Waldenström's. I think they were having some issues of some kind, which obviously eludes me. But it looks like we are really moving into the world of immunotherapy with Waldenström's with all these products.
George, excellent overview. Thank you. Just short questions. It's any role for autologous transplantation in the treatment of Waldenström macroglobulinemia?
That's a great question. I get that question outside the United States a lot. I think everybody is a little bit different. So whenever I present data from Dana-Farber, my experience, I always say is biased data. Because the patients that come to Dana-Farber tend to be younger, higher incomes, higher education levels, better social networks, right? So it's a different patient. It's not the average patient. In my clinic, I really have not recommended autologous transplant to many patients. I would say over the last 10 years, if I've recommended transplant, maybe in about 6 or 7. In my opinion, transplant is a good option for patients who went through a couple of lines of therapy, very young age. I think I would recommend autologous transplant in that setting. But otherwise, I don't think there's too much of a role. Now, outside of the United States, when there is not a lot of access to BTK inhibitors or BCL2 inhibitors or even proteasome inhibitors in some cases, then I think it's reasonable to think about autologous transplant a little earlier, specifically in young individuals who have gone through 2 lines of therapy relatively quickly.
I have a question about polyneuropathy. After treatment with the disappearance of paraprotein, this painful neuropathy still exists. Do you think it should disappear in the time, or shall we look for another reason for this polyneuropathy?
Let me start my answer by sighing.
Yes.
That is the bane of my existence. It's very difficult to know when to treat, how to measure responses. I believe that the deeper the response, the better off the patients are going to be. And I think that's an intuitive answer. But I think it has to do a lot also with how advanced the neuropathy is, how likely it is that it's related to the disease, which is...
How difficult it is
I can give you a 2-hour lecture on neuropathy on its own. I'd be happy to answer questions about this because it's a long problem. We do have a clinical scoring system, bilateral, symmetrical, distal, sensory, anti-MAG, demyelinating. That's what, in our opinion, is the most likely neuropathy related to IgM, even though there might be other more atypical processes, like with cryoglobulins or with amyloidosis and others. And obviously, to predict who is going to respond, that is actually very difficult. So what I tell my patients is, I want to treat you. There's a 50% chances that I'm going to stop it. 25% chances they're going to get better, 24% chances they're going to get worse, even if we actually get you to a very nice response. And they need to go in knowing that is the case. It's very difficult.
Okay, thank you very much. My feeling is absolutely the same.
Zienkunje, thank you. Oh, one more question here for...
You told that you are 10 years in Boston, in Dana-Farber, and during this experience, it's a unique experience in one place, in one disease. How you treat in 2023 Bing-Neal syndrome?
That's a great question. So the treatment for Bing-Neal syndrome is limited to options that actually cross into the blood-brain barrier. What we tend to use at Dana-Farber is actually covalent BTK inhibitors. We do know that covalent BTK inhibitors do penetrate into the CNS, and we have some experience with ibrutinib, more limited experience with Zanabrutin, but that's what we're using nowadays, mainly in patients in whom we don't want to cause stem cell damage. Otherwise, you have the bendamustine, which is a plus-minus. You have fludarabine, which is very stem cell toxic. You have methotrexate, cytarabine, which are much more toxic as well. And that's pretty much what we have. We are starting to use venetoclax, actually, in Bing-Neal syndrome. There is some data that it can penetrate into the CNS. So we're actually starting to use it now. Hopefully, we're collecting our experience. I'm going to publish it very shortly. We don't have any data on CNS penetration with pirtobrutinib. So at this time, we're not really thinking about that just yet. So I would say covalent BTK inhibitors, chemotherapy, those are the treatment options we have at this time. Thank you very much.